Good afternoon and welcome to HIT Policy Update, a webinar tweet chat combo from healthsystemcio.com sponsored by OnBase by Hyland. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com, and I'll be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. You can use that to send in your questions as they occur to you. Leave the default set to all panelists, and we will take those questions later in the program. And you can download the deck using the URL on your screen, and it's at the bottom of some of our slides. Just so you see how we're going to spend our time today, first we're going to hear from our featured speaker, Dr. John Honka, CIO at Beth Israel Deaconess Medical Center. Then we're going to hear from our sponsor, represented by Lorna Green, Manager of Global Healthcare with OnBase by Hyland. So without further delay, we're going to turn it over to our good friend, Dr. John Halamka. Thanks for joining us.
Oh, absolutely, and thanks, Anthony. I always enjoy doing these things every quarter, and as I say, it's so hard to imagine that we have such novel material every quarter, but here we are, once again, with novel stuff going on. And so today, I'll reflect a bit on what is the Trump administration thinking and what will it do, what do we see Congress doing, but also reflect on our industry and some of the major trends we're seeing out of the private sector and out of the innovation economy, and also reflect on some of the things that I've been doing internationally, because hopefully some of those international lessons learned can apply to the United States. So there's our agenda. We'll look at the EHR vendors, the Trump administration 21st century cures, and the next wave, the new thing. So let's start with EHR vendor updates. So I think at this point in history, as 2017 ends and 2018 begins, we all recognize that although there are the Allscripts and the Next Gens and the GEs and the 750 other vendors of electronic health records, many for niche marketplaces, much of our industry is driven by these 5 vendors, Epic, Cerner, Athena, Meditech, and eClinicalWorks. So if you ask, what are they doing, where are they going, what is their attitude toward innovation? So Epic, I'm sure everyone has seen, is going to have 3 versions of its electronic health record, in effect small, medium, and large, as it starts to migrate to more of a remote hosting offering, so that instead of having that big on-prem installation with thousands of servers and licensed software, you can imagine that as they start to become more and more a player in less than academic health centers, they pick up community hospitals or multi-specialty practices, they're going to want to offer a lower cost choice. And in effect, it's the same code base, but different configuration so that you're paying for fewer features and you get just the right-sized, good enough feature set you need. And what Judy's been talking about is the migration of the EHR to the CHR. And of course, people say, well, what's a CHR? And a CHR would be the comprehensive health record that includes social determinants of health and information that might be patient-generated healthcare data, the Internet of Things data from your home. And her thesis is, if we are going to be paid in a value-based purchasing world for outcomes and wellness, we better just have more than what today's electronic health record is encounter-based. You go to the doctor's office, you have your 15-minute visit, you get a chart, you get a bill. Wouldn't we want to see, did you walk today? Did you eat today? Did you take your medicines today? Do you feel safe at home? Do you have the right social supports that are going to make you successful in your quest for wellness? So, this is what Judy's thinking, small, medium, and large, remote hosted medical records, lower cost, more data elements, and more of a focus on outcomes and wellness. Cerner. So Cerner, of course, has some similar ideas, and it has embraced a set of standards, the Smart on Fire protocols, that enable an ecosystem of third-party developers to create add-ons that will just plug right into Cerner. So you ask the question, is it these 5 companies that I have listed on this slide that are going to give us the breakthrough innovations in 2018? Or is it going to be the 26-year-olds in their garages that are creating novel ideas? Who knows? You know, social networks for health, things that we may not have even envisioned last year. So Cerner's notion is that since those innovators, that ecosystem, will need data, both written and read from the electronic health record, that we should have a standardized way of making plugins. And so that's much of Cerner's work, although they continue work on improving usability of their record, population health and care management. The big move is Smart on Fire and apps that layer on top of Cerner. Athena, of course, has its More Disruption Please program, and like Cerner, is thinking that the future belongs to these apps that layer on top of the transactional system. So sort of think about it, if Athena is the iPhone, then there's still going to be thousands of apps by thousands of developers that will run on that iPhone. And truly, I think the only challenge Athena has as we end 2017 is its activist investor, Elliott Management, who acquired 9% of the company, and Elliott just has a tendency to replace senior management and wrap a company up for sale. So Athena, continues to do innovative things, continues to embrace external vendors, but is also having to manage this activist investor. Meditech, which has often been described as, good stuff at a reasonable price, but, not necessarily always on the cutting edge of innovation, is also, like the others, more often opening up its data so that third parties can connect to it. Although Meditech certainly is following the FHIR standards, another thing they've done is replicated the data from their record into a relational database, and then they make that data repository available to developers to read and write from. So theme here is more and more openness, more and more embracing of third parties and innovation, which will result in more data liquidity, more data shared with more people for more purposes. Of course, eClinicalWorks also continues to embrace a number of these trends. eClinicalWorks has announced its support for open notes, the idea that every patient will see their information written about them, including the note, at every visit. And eClinicalWorks, of course, had a recent Department of Justice settlement for $155 million around questions of the certification process for meaningful use. But I was with the CEO of eClinicalWorks last week, and he remains optimistic and energetic, and despite the Department of Justice activity over the last year, is committed to the next generation of innovation and embracing open standards. That's, our vendors. These 5 seem solid, seem like they're going to provide us with a good ecosystem for innovation around them. And so what is the Trump administration going to do? So I have been asked by a number of folks in the Trump administration to offer commentary on what focus over the next couple of years would be helpful. And so first thing that I've told some of our administrators is make sure that our electronic health record vendors, when implementing application program interfaces, as you'll see in a moment, which is required by the 21st Century Cures law, that they're read-write. It's pretty hard to build an open table application to make a restaurant reservation if you could only see the open tables and not claim one. And that's we just need to be sure, because I know the vendors are starting with a lot of reading of data, that we open up the EHRs to write back through these new application program interfaces. I was talking to one of our senators, and I asked this particular senator, what is interoperability? And this senator said, every data element in your lifetime medical record exchanged with every person for every possible purpose in real time at zero cost. Well, if that is your definition of interoperability, Anthony, we might as well all just go home, right? Because it's just not going to happen that way. Right. And so rather than having various government leaders say, oh, we lack interoperability, a meaningful use was a failure, EHR vendors are blocking data, why don't we actually decide all together as a society what interoperability means, what use cases we think we need to support in 2018, what test beds we should put up in a public way so that we can actually make sure that those use cases are supported. Because in some ways, although, meaningful use was okay, it got us to a foundation of functionality, which I think, was important. It was a bit of a market failure that EHRs weren't adopted by doctors and hospitals so widely until we had the stimulus, so we give credit where credit is due to meaningful use. But we really didn't, in meaningful use, say, you know what interoperability is? It is the notion that I would be able to take your problem list, your medication list, your allergy list, and send it from doctor to doctor using a nationwide provider directory over a straightforward, secure channel with one set of policies. We just didn't do that. We ended up with 50 different sets of state policies. We ended up with no doctor directory. So as I wrote in a recent article, it was a bit like saying, doctors, here's a car, there are no roads, you better drive. That's kind of hard. So let's define what use cases we want to support, put up public test beds to make sure that the EHR vendors' products out of the box support those very narrowly defined use cases, and then recognize that year to year we're going to expand the kinds of interoperability use cases we want, from push to pull to research to precision medicine, etc. In the 21st Century Cures Law, which we're going to review in the next slide, it says EHR vendors must offer APIs. But it doesn't say what APIs, how they should work, what standards they should embrace. So it certainly could be that Epic, Cerner, Meditech, Athena, and eClinicalWorks will have totally different APIs. So wouldn't it make sense for ONC and CMS to say, use these APIs? Use FHIR, something that is consistent and common. Now, one challenge you'll see in the 21st Century Cures Law, the word information blocking, which is, oh, gee, somebody woke up this morning and decided to specifically withhold data from you. Well, I don't really see that, and I know I'm very controversial in making this statement that I don't really think information blocking per se exists. What I see is a lack of economic incentive and priority to share data. So if a two-doctor practice, Anthony, you're in New Jersey. So if a two-doctor practice in New Jersey asked me tomorrow to arrange bidirectional interoperability, I would say, well, I could, but I got 200 critical projects about merging $5 billion worth of health care across 13 hospitals in Massachusetts. So let's say this. I'll put New Jersey on the list.
Right.
It's just that it's not that I'm blocking. It's there isn't an economic incentive to work on that particular project with priority. So let's make sure that what we have as a national policy is that we have a business model, a business case for exchanging data. Not that they're going to do this, but imagine this. Doctor, you will not be paid until you exchange the patient's summary of the visit with the next provider of care. Well, I guarantee you, if you had something like that, data would flow tomorrow. And ultimately, I think what you're going to see over the next 3 years is that the private sector, collaborations of industry, academia will lead. You're not going to see meaningful use stage 5. You're going to really, maybe, as you'll see in the next 2 slides, ONC will work on 21st Century Cures because there's a lot in there that ONC has to do, and we'll probably see a lot of deregulation, but we're probably not going to see a lot of prescriptive regulation. So the private sector should lead. So that's, in effect, what I've told the Trump administration. So let's take a bit of a deeper dive on 21st Century Cures just so you understand what that 1,000-page bipartisan law says. So I'm not going to read every one of these, Anthony. Don't worry. I've 1,000 pages of 3 slides. Section 4001, really, that's a code word for reduce burden. Right? So if we, in meaningful use stage 1, 2, and 3, created so much typing for doctors that they can't actually look at their patients anymore, how do we divide that work? up into multiple people on the team. Sometimes it's the doctor, sometimes it's the nurse, sometimes it's the patient and their families. How do we just be careful that we don't have so many quality metrics, that we're putting in so much data that's not so value added that doctors can't practice medicine? Next section is just making sure that we know that as electronic health records were created for meaningful use stage 1 and 2, our vendors didn't really have the time to look at the usability of the applications they were creating. They had to comply with thousands and thousands of pages of regulations so fast and then get these things out into the marketplace. They didn't really have that breathing room to reflect on things like, is it easy to use, is it safe? And so Section 4002 tries to give them that breathing room and encouragement to report on usability. As we go into Section 4003 and 4, it gives the OIG the ability to actually enforce sanctions on organizations that are specifically prohibiting the flow of data. And as I said, I don't think that the OIG is going to go after somebody because they didn't share data with a 2-doctor practice in New Jersey, but they would probably go after somebody if you started refusing to give any data in your community to other providers or to patients. I mean, something that was truly volitional and not just a question of alignment of incentives and priorities. So there's some teeth to the idea that we'll make information flow. Section 4005 and 6 are more about giving patients more fluid access to their data. And although it's true that meaningful use does require things like patient portals, so one problem is you have 5 providers, you probably have 5 portals. And wouldn't it be wonderful if you could have an app on your phone that would be able to draw the data from all the places you've ever received care and put it on a single secure container where then you could view it, you could be steward of it, you could add to it, you could share it as you will. And that's the vision that 4005 and 4006 are, that we're going to be able to make APIs available for patients to have access to their data and do creative things with it. One challenge, and this is in Section 4007, is, Anthony, has your name ever been spelled wrong? 2 R's, 1 R, you know, no you, you know. So the challenge is, how do we even know who you are? And if we're going to have more data sharing, provider to provider, provider to patient, and then clinical trials and research and quality metrics and everything else, we probably need to have some nationwide patient matching strategy. Note, I didn't say national healthcare ID. You know, I don't think in the next couple of years we're going to see the government issuing an ID that we'll carry around for life, as has happened in many other countries, but some strategy. And that strategy may very well be biometrics. You know, it's going to be fingerprints and retinal scans or iris scans or stuff that you know in addition to stuff that you have. So the address I used to live at when I was a kid, plus my fingerprint, plus my driver's license, you know, that's pretty good for an ID.
Right.
Yeah, so the GAO, the Government Accountability Office, has been commissioned in this law to do a patient matching study to look at the costs and benefits of a nationwide patient matching strategy. And there are a variety of other organizations like the Pew Charitable Trust, the RAND Corporation, and Chime, all working on this. And I was telling Anthony and Lorna, I was in South Africa a couple of weeks ago. The Gates Foundation has decided that in order to improve HIV care across the country of South Africa, they need to build a way of having data follow the patient wherever the patient goes. So what did we do in South Africa is we've implemented prototype biometric scanning units, very cheap, you know, $100 per clinic, so that you walk into a clinic, we do iris scanning, and then all of the data about your visit at that clinic is not only stored under your iris, but it's also sent to you, to the device that you own. So you have an electronic wallet you carry with you, even on the most very basic of phones. Doesn't require an iPhone 10, right? This is going to run on simple phones. So the Gates Foundation challenge is use biometrics, use very simple phones and simple phone networks, and then enforce the integrity of data across the country. There's also a little bit of blockchain that's being used to make sure that the data has integrity. So we'll let you know, probably our next call, Anthony, as to how that's going.
Very good.
21st Century Cures suggests something like that might very well be done in the United States. Now, just the last couple of things that this law states. We know that although patients have access to portals, we aren't seeing that wide adoption of patients being stewards of their own data that we would have hoped. And the question for the Government Accountability Office is, well, why is that? Maybe the portals are just hard to use. Maybe they're not value added. Maybe you need to rethink what a patient-family engagement looks like. And then the last one, 4013, is about enhancing telemedicine and telecare services and figuring out a rational reimbursement methodology. Because if, in fact, we are going to keep patients healthy and get paid for outcomes, wouldn't it be wonderful to be able to have primary care visits in your home today when you're sick, and that doctors would be paid for doing that? So, working through all the logistics. I mean, there are already CPT codes for telemedicine services. It's just no one knows quite how to use them. So there's just additional study to do. So there you go. There was 1,000 pages in just a couple of slides. So what's coming next? Here we are entering 2018. I've given you some themes about what Cerner, Epic, and Meditech are doing, opening up their electronic health records. I'm going to call that deconstructing the EHR. And what do I mean by that? Instead of just one monolithic thing you buy from one vendor, what we really are looking forward to in 2018 is, you don't like the dictation that you use today in your EHR vendor? Who cares? Here's an app for that. And that app, because it has the ability with these APIs and FHIR standards to read and write from an electronic health record, provides you a much better experience for dictation. Or maybe patients can schedule appointments with you via an app, and it's really updating your schedule in your EHR via FHIR. So these are the sorts of things that I see happening. It's taking niche functions that EHRs don't do very well and now giving them to innovative companies, deconstructing the monolith that is the EHR. We're also starting to see a trend where in a value-based purchasing world, it's really important to understand where your patients are getting their care. I don't know a whole lot about the New Jersey marketplace, but I'll make something up, because I have no idea if this is correct, Anthony. That Robert Wood Johnson Medical Center is really cost-effective and high quality, but Rutgers Medical Center, who knows if they even have a medical center, isn't. Well, then if you were a care manager, wouldn't you want everybody to go to Robert Wood Johnson Medical Center and not Rutgers Medical Center? And so if you had in a region admit discharge transfer data that went from organization to organization, every time you show up, inpatient, outpatient, skilled nursing facility, emergency department, urgent care, ambulance call, that a pub-sub approach, a publication of that admit discharge transfer information to subscribers who care will happen. So maybe that goes to your care manager or care navigator. Maybe it goes to your primary care physician. I mean, workflow to be determined. I'm seeing this especially in New England right now as a very hot technology, and lots of companies getting involved in helping us figure out getting the patient to the right place for the right treatment at the right time at the right cost. Now, this one's going to sound a little bit like it's the Gartner hype curve, but one of the things we've started to do at Beth Israel Deaconess is use Bluetooth low energy beacons in rooms, on patients, and on doctors. So, for example, how much time in a hospital do you waste trying to find, where's Dr. Smith? He was here a minute ago. Where's Nurse Jones? Or where's the patient right now? So what we've done is through the use of these geolocation beacons that are just $1 and you glue them to the wall, or they're a wristband or a card you wear, we've built actually an Alexa interface. So you could say, where is Dr. Jones? Dr. Jones is in the radiology suite on the 3rd floor, room 105 right now. Where's the patient? The patient has gone to the cafeteria. These sorts of things we think can really improve workflow. Because we think the EHR, as we know, is sort of a way to document a visit and get a bill out. It isn't a workflow tool. And you start working these things like geolocations and beacons and Alexa into it, it becomes a much more usable tool. Yes, you will see the word blockchain all over the industry right now. And I just want to offer a bit of warning. Be a little careful. This sort of reminds me of the Dutch tulip thing. There was a point at which, tulip bulbs cost as much as a house until they cost nothing. With blockchain, you're now seeing everybody promise, interoperability will be fixed. The whole medical economy will be turned upside down. Blockchain will save us all. Well, there are really great use cases for blockchain, such as, and, Anthony, I'll make this up because it never happens, but let's say a Harvard doctor gets sued for malpractice. Okay, it does happen, I admit. Well, what happens often is a plaintiff attorney says, send me all the medical records from 17 years ago. Wait a minute. Okay, I'll do my best. And then the plaintiff attorney says, but these have been altered or they're incomplete. And then I say, well, I'll produce the audit trails. The audit trails are fake news, right? So it's a problem to guarantee the integrity of medical records in a legal setting. So imagine this, that as a doctor signs a note, a hash of that note is posted to a blockchain. 17 years go by, and you can say, look, here's a tamper-proof public ledger, and it shows that there's this hash, and it matches the hash of the note. There's guaranteed no alteration and completeness. So those, just as you're evaluating blockchain solutions, just ask yourself, why blockchain? If it's for auditing, tamper-proof nature, being able to track integrity, that's all good. If they say it will replace relational data technology, not likely. There's no such thing as big data analytics on blockchain, although I'm sure there'll be 5 booths at HIMSS offering it. And finally, machine learning. The last thing that I'm going to end with is what is probably the most overhyped term, but yet a very important technology to watch. And let me just show you some examples. This is going to sound somewhat boring, right? This is not IBM Watson will replace your doctor and, all medicine will be done via your iPhone. No. What this is there are great machine learning applications that just help augment what humans do today and help streamline the workflow we have today. So example, it turns out that Anthony can do an appendectomy in 25 minutes, but I can do an appendectomy in 5 minutes. But yet both of us are given 1 hour of OR time. Why is that when the OR is the most expensive commodity in our hospital? Shouldn't a machine learning algorithm be able to say, well, I've looked at the last 1,000 operations Anthony did and the last 1,000 operations John did, and I'm actually going to allocate OR blocks based on skill and experience and the patient who's getting a procedure today. We've done that. And it turns out you can free up 30% of your OR capacity by doing something like that. Or another quick example for you, we get 18 inches of paper every day. And humans read the paper. Oh, that's a CAMP form. That's a lab order form. That's a consent. Well, we asked the question, could Amazon Machine Learning Services figure out what a CAMP form looks like if we gave it every variation of CAMP form we've ever seen? And the reality is 99% of the time, Amazon can effectively categorize the pieces of paper that come into Beth Israel Deaconess so humans no longer have to read them, and it can insert them into the right record, and now humans just look at the exceptions, the 1% that it can't quite figure out. So these are just some examples. Machine learning is real, machine learning is useful, you just have to pick your use cases. Well, Anthony, there you go. There is our quarter's update on Trump's thinking and legislative activity, technologies in the marketplace, and lots going on. And, of course, I'll see everybody at HIMSS, where I'm sure between now and then half of Congress will resign. So who knows what will happen.
Very, very good. Wonderful, enjoyable, always informative, and I'm looking forward to our Q&A. So we'll get to that in a few minutes. But first, we're going to hear from Lorna Green, who is with OnBase by Hyland, and they are our sponsors, and we want to thank them very much. So thank you for joining us, Lorna.
Thank you for letting me be here today. And as always, Dr. Halamka, you bring up good things to think about, and it's really just good information. So thank you for that. And happy holidays to everyone while I have you on the line. Today, I want to talk to you just a little bit about Hyland Healthcare. In the past, I've talked to you about Hyland OnBase. OnBase is our ECM product, but now we have a broader term, Hyland Healthcare, and specific to that is we have an enterprise medical imaging suite. All right, I got it to go, Anthony, so we were wondering if I had control. Thank you. So Hyland's enterprise medical imaging portfolio is composed of our VNA, Accuo, the nil-read, zero-download enterprise diagnostic viewer, and our PaxGear suite of capture products. These EMI suite provides the infrastructure required to gain control over the complex and multi-facility medical environments that we're seeing this day and age. These are the core products of our EMI solution, and a significant portion of Hyland's future R&D pipeline is going to be spent on developing these products. But we also want to make sure that everyone knows that OnBase, our ECM solution, is still in the picture. So when you add an ECM solution to an EMI solution, that gives organizations the ability to connect, manage, view, share the longitudinal patient imaging record. And, you know, as Anthony was talking about the value-based care and the ability to have portals and see data, share information, this gives us the ability to pull data from the ECM portion and the imaging portion of OnBase into one place and make it viewable through your EMR so your clinicians only have to go to one spot to see a full patient record. So, as I said, enterprise imaging can deliver end-to-end clinical visibility in 3 ways. We can capture using our products and integrate all those images into one place. Helps us manage information that could potentially be in silos now or different places in the hospital, and then also gives you the ability to view, access, and interact with the medical images. And when I say medical images, we're not just limiting that to DICOM. We're talking about any type of images, whether they are photographs, visible light images, that type of thing. So using our enterprise imaging products, it gives you access to all medical imaging content, which is critical to making informed clinical decisions. Sorry, my clicker just won't seem to go. Specifically, I want to just end with telling you about our nil-read enterprise viewer. It's a comprehensive zero-footprint platform, and we have now integrated it into our OnBase patient window, which is part of our OnBase suite of solutions, and the nil-read viewer is embedded in that. So it will give a clinician a single place to view all information about that patient. As I said, it's zero footprint, directly reads from the Accuo VNA. Multi-platform, it can be utilized on mobile, smartphone, tablet, notebook, desktop, and it's multimodality, art, radiology, cardiology, ophthalmology, all the different organizations that have different groups, and it's DICOM, TIFF, JPEG, so it is multimodality. If you have any interest in learning more about how our OnBase imaging EMI, enterprise medical imaging, sorry, I'm getting tongue-tied, will help your organization, please feel free to contact me, and I can get you contact with someone that can give you more information. Thank you.
Thank you, Lorna.
I'm done being tongue-tied, Anthony.
Well, you say that 5 times fast, right? Not that easy. I challenge our audience to try that one. Thank you very much, Lorna. We appreciate your joining us and your sponsorship. Now we have time for our Q&A. So if you've got questions, send them in the Q&A box, and we will get them in front of Dr. Halamka. Dr. Halamka, first question that came in ahead of time before we started the event. I'm curious as to what policies or regulations are changing in relation to IT security. Under meaningful use, an assessment and action plan was needed, and most used the NIST framework at the time. At the time it was released a few years ago. I understand some of that has changed or is changing, question mark. What does the future hold for IT security in healthcare? Oh, hold on, let me get you off mute there. Go ahead.
Can you hear me?
Yep.
Can you hear me now?
I can.
Okay. Right, so let me give you three trends. So trend number one is, as we all know, cybersecurity threats are escalating in both their intensity and sophistication. So I would tell you 20% of CIO time is spent thinking about cybersecurity. Lots of money going into increasing capabilities and staffing to defend against this onslaught. On the regulatory side, certainly I have had meetings with Department of Justice officials over the last couple of years, talking really more about not so much legal requirements, but banding together with resources inside and outside of government so that we can all defend ourselves against these attacks better. I mean, to my knowledge, the nature of regulation and legislation is more about just make sure you choose a framework, whether that's NIST or COBIT or ITIL or HITRUST, and then make sure you have an audit to identify risks against that framework, and then document your mitigations every year, knowing you'll never be done, but you just every year will get better and better and better. So, it's not so much that I see new laws coming down the pike. I see just more and more awareness and collaboration and formalism.
Very good. All right, the next question, I'm gonna rephrase it as best I can. I think the idea behind this question is that in the past there had been some protections that the government was trying to put in place to help consumers, such as certification. So that was one step that was put into place to help buyers of technology. The person who asked the question mentions that a lot of people are sort of having major upgrades, one product to the next product, maybe one EHR to the next EHR, one revenue cycle to the next revenue cycle, and there's huge risk, and there are failures that happen in these kind of upgrades or switching products. Do you see anything else coming down the pike from the government in order to provide more protections, perhaps something like certification or anything like that?
And this, interesting issue, which is Don Rucker, our national coordinator, is a person who really wants to be a convener. He really wants to make sure that the private sector has the opportunity to innovate, but he isn't so much a regulator, right? So that is, I don't necessarily see that government is going to regulate in a more stringent fashion the products and services coming out of our electronic health record vendors. Now, there may be more transparency, reporting, awareness, those sorts of things, but it'd be likely, private sector collaboration rather than government imposing its wishes on the private sector. What you hope is that in a free market economy, that we will be able to assess which products are fit for purpose, and people will buy those. And so in some sense, the market will decide, which is why I think we're starting to see certain healthcare IT organizations grow and others shrink because of things like product quality and usability. So you just assume, my summary, government over the next 3 years will probably not be the leader. It will be collaboration, convening, and private sector activity. Very
good. You had mentioned in previous updates with us that you had not been contacted by the Trump administration. Now you mentioned today that you have been and you're being consulted with and your knowledge is being tapped, which is certainly encouraging. Do you want to give us any more information about when that occurred and sort of your takeaways from the nature of that interaction?
Well, sure. I mean, a couple of things. I mean, Don Rucker, as our national coordinator, comes from Beth Israel Deaconess. He was a Beth Israel Deaconess emergency physician with me for a decade. And so he obviously serves many stakeholders across the healthcare industry, but I do speak with him fairly frequently, and I think Don, as is appropriate, will say, oh, here's a standards question, or here you need to speak to, a CIO in the trenches. He will refer others in government to speak with me. So, of course, as you said, Anthony, I'm not doing anything formally, right? I have not been appointed to the Health Information Technology Advisory Committee, and I am not serving in any kind of position other than I am a stakeholder, and Don and others are asking me about my experience as a stakeholder.
Okay, very good. You mentioned the patient matching issue, and you even mentioned Chime. As you probably know, they shut down the challenge they had to try and come up with a patient matching solution. One would imagine that would indicate this is pretty tough stuff. So any thoughts on that and what it means about the nature of the problem?
Yeah, and Russ and I have not specifically talked about why they shut down their challenge, but I'm guessing that they had asked for 100% sensitivity and positive predictive value. Now, I don't know about you, but I mean, I can't with 100% certainty do anything. I mean, I'm not really even sure, that my coffee is organic, with 100% certainty, right? Nothing is certain in life. And so if that's your demand, it's probably asking too much. And so in the work that I am doing in South Africa, we're asking for not 100%, but we're asking, high 90s in positive predictive value with few false positives, right? Because the false positive is the thing that's really bad, right? Because, Anthony, we commingle you and Lorna's medical record, that could have very bad consequences. If, on the other hand, I couldn't find your medical record, I mean, it's a problem. It's just a less serious problem. So we're shooting for high 90s with very few false negatives. So I think we'll be able to achieve that using the combination of demographics and biometrics in South Africa. And Chime maybe is just setting its sights very high. Okay,
very good. You talked about deconstructing the EHR and the fact that you can have a platform-type environment with apps being written on it. That's really up to the vendor, right? I mean, no one can allow the deconstruction of their EHR but them. They're the ones that can decide whether or not any component you can plug something else in. Is that correct?
Well, let me answer that in 3 ways. God, this is a theme.
That's a lot.
So remember, 21st Century Cures requires that the vendors offer APIs, right? So it's a law. So now, admittedly, 21st Century Cures is APIs for patients. But if there's a law that the API must be there for patients, I mean, chances are there are going to be ways to use it in creative fashions for even, maybe it's patient-mediated provider exchange, or who knows, right? So clearly there's a law. 2, I'm seeing every EHR vendor want to do this. Because in the world that's post-meaningful use, everybody has an EHR, so the vendors have to figure out something else to sell, right? So they're going to want to offer population health and care management and new add-ons and components and all the rest. So the vendors, I think, are very much interested in doing that. Well, and the third way to answer it is there are companies, and Anthony, I don't have stock in any of these companies, and I don't endorse any company, but there are middleware companies like Redux, Sansoro, Acmeware, Iatric, all these other companies out there that specialize in building bridges to incumbent EHRs so that apps can then use those middleware bridges. So even if the vendors were reluctant, there are middleware companies that would get around that reluctance.
Very good. Next question, is your health system, BIDMC, applying the artificial intelligence technology to physician office scheduling in addition to OR scheduling?
And so in our dozen or so projects that involve machine learning and AI, we have three broad categories we're focusing on, and one is throughput, right? So whether that's inpatient throughput, predicting who will be discharged when, or outpatient throughput, how can we ensure we get that next available appointment in a timely fashion? How do we get the person out of the ER? How do we open up the OR? So the broad answer to that is it is in our throughput initiative stack.
Very good. All right. I have a final question, and it's a little different, and it's sort of based loosely off one of the postings on your site, notes from a broken health system. We talk about population health, we talk about value-based care, we talk about opening up the EHR to social determinants and making it a CHR, whatever the case may be. So let me give you a scenario. If I am an individual with a very serious chronic condition, and I see 4 or 5 specialists, and I've been to 2 or 3 health systems, what would be the best way for me to get that care coordinated, or be able to collect the information and provide it to anyone who needs it in the easiest way that's going to be for me? Is it an idea of I have some sort of PHR, and everywhere I go I say, okay, great to see you. We need to dump everything that you've said and everything you've done and every test you've had me take into my little PHR here, because I got a lot of other places to go. And then you can go to the next provider and say, here's my PHR. It's got everything in it from everything everyone I've ever seen. Oh, and by the way, make sure you dump everything in here. Is it a concept like that, or is it more of getting these physicians and these health systems to send that information perhaps also to me, perhaps not to me, but to each other? So again, what's the best way for me to get my care taken care of today, and then where could we go with this? What do you want to see the scenario be in a perfect world, or in 3 years from now, to make it better?
Sure, and we do all of the above, the things that you have mentioned. So ideally, you, the patient, will be the steward of your own data, and on your phone there will be an app. We've created an app called BIDMC at Home, where you will hold all the data from all the care at all our sites on your phone. And once it's there, you can do with it as you will. Not every healthcare system is going to support that, but we hope that over the next couple of years that becomes extremely commonplace. We also send data from provider to provider. The meaningful use, CCDA, using the direct protocol, will go from one provider to another provider, and a payload goes across and is incorporated into the receiving EHR. And that will also continue to be a way of doing exchange. But there's another way that, in a value-based purchasing world we're working, which is we send all data from all sites, inpatient, outpatient, urgent care, SNF, et cetera, to the care manager, and the care manager has the assemblage of all of your fully integrated, curated data, and then helps you as a servant with care navigation. And that's part of our ACO, because in a world where you're paid for outcomes and wellness, unless you have a care navigator, it's really hard to get the appropriate care at the right price.
And so when, that piece that appeared on your site that was very disturbing about what that woman had to go through, even to get appointments, your thoughts on how that could work, how that should work, how things should or could be changing so she doesn't have to go through what she went through. And I'll refer anyone on the call today to your site, and I'm sure they can easily find that piece.
Right.
It was quite impactful.
And there's going to be a part 2 coming in the next couple of days. More and more stories and dispatches from broken healthcare systems. So, what you ask me is kind of it's a cultural issue. We aren't a national health service. Yeah. And we don't have a right to health care. And birth to death, the government will provide us this as a service. So, this is something we could spend 2 hours debating. As I travel the world, I'm often asked, what is the best healthcare system I have ever encountered? And the answer to that is Denmark. Because right? In Denmark, you have fluidity of data from provider to provider, provider to patient, patient to clinical trials and research. You have all of the appropriate privacy protections so that people are respected, but yet there's one set of policies and governance, and you have a national healthcare system with a national patient ID given at birth that tracks your entire record across every provider for life. And it's a societal provided function, so you don't have to debate whether you can get an appointment or not. So sure, we can build the electronic tools that I've described on this call to help us, but we've got some real cultural challenges we probably have to overcome as well.
Very good, very good. Thank you so much. All right, that's about all we had time for today. When you close out your WebEx window, you'll be taken to a post-event survey. If you could take a moment to answer that survey, we would certainly appreciate it. For those of you holding the CHCIO certification from Chime, attending our webinars gets you 1 CEU, so let Chime know you were here, and if you've asked us to do so, we certainly will. You'll receive an email when this recording has been posted to our YouTube channel, which will be very soon. And if you'd like us to produce a webinar on the topic of your choice, you can contact Nancy Wilcox on our team. And of course, go to our website to see our upcoming schedule of events. So with that, I want to again thank our good friend Dr. John Halamka for joining us. I want to thank Lorna Green for speaking, and I want to thank OnBase by Hyland for sponsoring. Once again, everybody have a wonderful day. Thank you.
Thank you.